So I'm very honored to be here. I'm really very happy to be part of this community. I was going to say yours, but it's ours now. It's our community. I was reflecting as I was coming in this morning, how the strange paths people's lives take, and I'm really very happy about this path that mine has taken. I couldn't not think about the terrible tragedy that happened in Tumbler Ridge yesterday, and I think it permeates everybody's thoughts this morning. But let's keep going. So I want to start that our work takes place on the traditional, ancestral, unceded territory of Musqueam people, but also on the territories of Tsleil-Waututh and Squamish people. But majority of the work that I will be talking about has been conducted on the land stewarded for millennia by the Haudenosaunee, Anishinaabe, and Mississauga of the Credit First Nations, but also lands that are now inhabited by the Chippewa, the Wendat, and many representatives of First Nations, Métis, and Inuit. And especially when I talk about some of the data that were collected on a Canadian scale in a number of provinces, and clearly, our work has been conducted on lands stewarded and cared for by many Indigenous nations in Canada. So we have 4 learning objectives, but they kind of in the materials that you probably have seen. So I'll just cut straight to the chase. I think my first kind of point for the day is talk a little bit about data systems for child health. And it's not a very complicated concept, but I found myself, and you'll see some of the work that I have been doing, working a lot in a space of population-wide data, population-level data, and having conversations about, how these type of data can be useful for individuals. So the way things work in terms of data collections and data system is that you collect data for individuals, and it's led by the purpose for which the data are being collected. So you want to have a child assessment, you want to help this individual child/family, and you address, you kind of do assessments. Then often these assessments are being grouped to maybe evaluate a program to help a specific group of the society. I'm not sure why it's going automatically, sorry. But then and then, if this happens to be part of a larger data collection, then data become available at the population level. And then the population level data serve public health epidemiology, and the individual level data serve clinical purpose. But what we've been trying over the years with the data for early child development is to find ways to move that information also the other way, and find ways where the kind of two sides of the, let's say, magnitude of, maybe not magnitude of data collection, but of the level of the kind of precision of looking at child development can inform each other, not just one way. And I think, so what I would like to talk about a little bit today is to hopefully show you how that can happen, and what are still the areas that are left undone, where we can potentially improve, where I really hope, and at the end, where I really hope that I can benefit from all your expertise and everything that's going on here to work together to advance these ideas on a data system for child health. So what is child health? So this is obviously, and everybody, I'm sure who's listening knows, it's not just an absence of illness, but in the process of developing a way to look at child development and at the population level, this concept of developmental health has been coined by Clyde Hertzman. So here I just want to say that my roots, my connections with UBC are going up, reaching very, very deep. So in a chapter published in 1999, Clyde Hertzman suggested this concept of developmental health, that it's more than more than the kind of ticking off developmental milestone. It's a holistic concept, including all domains of child development. So, and there also that allows us to put child developmental outcomes as a reflection of the early childhood experiences at home and in the community. And the instrument that was designed, co-developed by Dr. Dan Offord, another of my mentors, and myself, is called the Early Development Instrument. It's a population-wide measure, population-wide by the way of implementation. Every child is being assessed by their teachers in 5 major developmental domains: physical health and well-being, social competence, emotional maturity, language and cognitive development, and communication skills and general knowledge. And these are the data that I will be talking mostly about today. I'm not going to get into any more details, but feel free to ask any questions you want. Just a quick overview what kind of data we have. So since the finalization of the instrument, data have been collected for 12, at least once, for 12 out of 13 territories and provinces in Canada. Actually, data were collected in Nunavut, but it was prior to finalization of the instrument in 2004 and not since. The overall percentage of children who are vulnerable, and that's a reference to a cutoff, nationally is 27, but as you will see in a moment, and that's much higher in males than in females. And children who live in disadvantaged neighborhoods are more than twice more likely to be vulnerable than those who live in higher income neighborhoods. And here I've arranged these provinces from west to east, not necessarily from highest to lowest, but you can see that Yukon, Northwest Territories have the highest percentages of children who are vulnerable, and Newfoundland and Labrador the lowest. So just think in terms of perspective. For these numbers, we take all the data that were collected for these provinces, not the latest ones. So those percentages will vary. And then obviously, so you already see that it varies from that 27% that I showed you overall. When you go lower and you go for regions within the country and then within the province and then neighborhoods, the variation could actually be between 0 and 100. So you can actually have schools and neighborhoods with that kind of high or low percentages. So again, that's kind of just to give you an example. In terms of what years we have in the data sets for those provinces, the ones that are in blue still have ongoing programs of data collection. Okay, so except for Quebec and BC, Offord Centre for Child Studies, where I have been until 2-3 months ago, and I still keep my connection there, processes data for every single school district in the data collection system. So we produce reports. So just kind of give you a little bit of a perspective, kind of check here. What comes back to the school district is something like that. So for children without special needs, and I will come back to the definition of special needs, but that would be children who have an already identified, mostly developmental need. You see that it's about, so the orange bars there are the provincial reference, but you see about 30% of children are vulnerable in this particular school district. There's about 3,000 children in that particular one. But when you look at the group of children with the special needs designation, you reach percentages like 90%. So this is, just looking at the population as a whole does not really give you, so there's a kind of reality check here. You really have to focus on children with special needs in order to find what actually is going on there. And one of the main things that I was really interested is whether the same contextual neighborhood process factors really influence their development as well. So when you use the EDI data to monitor developmental health overall, there are huge advantages. So we have this large coverage, 1.6 million children over 25 years. We have meaningful links with contextuals and neighborhood factors, because when you collect data for all children in a particular neighborhood, then you really can make some inferences about what matters. And there is a huge potential for link with administrative data. It happens in different ways in different provinces, and sometimes it works, sometimes it doesn't, but the potential is there. but there are challenges. So the linkages for equity deserving populations, we have data. If these children go to school, if they go to kindergarten, we have data, EDI data on them, but they may not show up in administrative data sets or not as easy as other people. And obviously the main challenge of data such as early development instrument is that there's really a bird's eye view. So you really don't get to see the nuances for individual families. And I think that's a major component that I would really like to expand my research program to. Already started, but these data are useful. And here are a couple of examples. So a few years ago, a pediatric anesthesiologist colleague of mine and I looked at the potential risk of exposure of neurotoxicity using linked administrative data. And we found that there was a little bit, for when children were exposed to anesthesia by 2 years of age, they had slightly higher odds of being vulnerable at 5 years of age, but it wasn't clinically meaningful. And when we followed it up with this study of siblings, we found that not only the effect, even though it was a little higher, this effect was not only not meaningful, but also not statistically significant. So that was good news. Sometimes, though, we find not such a good news. And this is a set of works that's from Manitoba, where we, not myself, but my colleagues in Manitoba, looked at children who were in contact with children and family services. And they found that 50% of children who have had contacts prior to school entry ended up being vulnerable on the developmental domains, or at least one developmental domains at school entry. And unfortunately, very similar patterns we see in places like New South Wales, which is Australia, where they also collect EDI data. And in Ontario, we had slightly different data, but the pattern is the same. Unfortunately, contact with exposure to violence, contact with services, and being in care is a huge risk factor for child development. So that's for general population, but in order, as I mentioned, in order to look a little bit more detail in a more nuanced way on children with special health needs, with developmental disabilities, we have ways to use the early development data. These are, and the highlighted categories here are the ones that I'll be talking in more details today. So we have the special needs category, and that's very much provincially designated. Ministries of education have their list of what kind of what goes into that, what the child has. Autism is very often the one, very serious learning disabilities, which have to be diagnosed by the time children reach school entry age. And in some provinces, that's 4 when they have the junior or year 1 kindergarten, and in some provinces, that's 5. We look at functional impairment. So these are problems that teachers have to report that the child has difficulty in, that interferes with their schoolwork. And that can be either teacher observed only or can be parent reported based on professional diagnosis or professional information. And there is 7 of them that are health-oriented, so sensory, speech, and behavioral emotional learning. And there's a few others that are more slightly different, like chronic illness, unaddressed dental needs, and home problems, which I also briefly mentioned. And we also, in the last few years especially, we started paying a little bit more attention to one question that we have: do you think, to the teacher, do you think this child needs further assessment? Because in the preliminary study that we did, we found that in the absence of any other indicators of special needs functional impairment, that was the most powerful predictor of children's special education status later on in their educational career. So we started looking at that in a little bit more detail, and that work is still ongoing. About 10 years ago, we were incredibly lucky to get CIHR funding for a study that we called Canadian Children's Health in Context study, or CHICS. And that was, by far in my career, the most successful project. It wasn't all that much money, but because it was a 5-year, it ended up in the pandemic year. So we got a couple of years extension, and we were able to keep adding data sets, because original data set was 2010, 2015. That's what we based the proposal for. And so we were really able to use that for many projects. 12 jurisdictions data are included, not in every study, depending on the timing. And we have medical diagnosis, functional impairments, and obviously the special needs category. And just to give you a brief, maybe again, a bird's eye view, like what does that look like? So clearly children do not belong in one category. And I mean, you must know that very well. There is so sometimes, when you look at a study or like you want to compare, make, a proper comparison of pure diagnosis, pure categories. This does not happen very often in real life. So, but the other thing that I wanted to draw your attention on this, I don't think I can point, but in the overlap of the three Venn diagram in the middle, you have children who have special needs category, they have at least one functional impairment, and they also have a medical diagnosis that teacher is aware of and put on the EDI. And that's only 1.3% of all children. But because of the size of our data set, it's 12, almost 13,000 children, which really makes you able to look at certain, so this is just an illustration. You are able to look in this still bird's eye view, but in a little bit more detail at children who have very low frequency conditions or combination of conditions. How do these children with these various special health needs fare in terms of their developmental outcomes? Well, in comparison to typically developing children that have only special needs category, there is 40% of them that are vulnerable on one or more domain at school entry. Children who have functional impairment only 70%, and then you have over 80% of those who have both. So in that school board report that you saw, we had almost 90%. We don't distinguish. So it's kind of everybody who has special needs category. That's why you have such high percentages there. If you look actually at odds ratios, so children with special needs only, which may be a little counterintuitive, that the children who have special needs, but if they don't seem to have a specific impairment that impacts their schoolwork, they actually not doing all that badly. Is that functional impairment? At least one of those that really increases their risk to not do so well. And then if you have both, that's really a huge risk factor. And then if you look, I only have 5 here, just for clarity. So the sensory and physical impairments are much less a risk problem than the learning and behavioral emotional ones. So that was kind of overall descriptive look. But what have we learned through the CHICS study? And I'm just going to show you a few highlights. So the first it didn't necessarily happen in this chronological, and I'm sure you're aware that things don't happen linearly in research, but it's nice to be able to present them in such a linear way. So we first really, because we did want to look at developmental outcomes, not just the cutoffs, we looked at validity of the EDI for children with special needs. And that was just, so really this were children with developmental disabilities mostly. And we found that there were very similar associations, especially with what was really striking, especially with neighborhood socioeconomic status. And I'll show you some other information in a bit later. But quite often people, when you go and talk to people, well, but they would say, oh, there's so few of them, or you can't say that. It's very special. Each family is special, and I'm not saying that our data deny that. It's just that all children, all families are subject to societal factors in, unfortunately, very similar way. Low socioeconomic status affects everyone. Poor access of to resources affects everyone. And quite often it affects children with special needs even more than children who are typically developing. The other thing, of course, if we wanted to use some of the diagnostic information that's on the EDI, we really wanted to know how accurate teacher reports are. That's a major challenge in using that kind of data. So we looked at 5 in a study. Once we were able to link Ontario data in administrative data set. Unfortunately, we haven't been able to do it again, but that study has been published, and we looked at anxiety. So clinically identified anxiety, not kind of anxious behaviors, asthma, ADHD, autism, and cerebral palsy. And for all of them, we had high positive predictive values, which is not surprising. But in terms of high reliability, we really had very good reliability for autism. Acceptable for cerebral palsy, but there was very few children in the sample, but not so great for the other three, which didn't necessarily stop us exploring these categories, but in this particular sample, it didn't show good kappa values. The other, so, like that's kind of gave us a little bit of boost to study autism in a little bit more detail. And, as you may be familiar with the Offord Centre, I have a number of colleagues there who really have done amazing work looking at children with autism. My colleague and friend, Dr. Terry Bennett, is now leading a study looking at intervention ways, family checkup model for children with autism. But so there definitely has been interest to kind of support that type of research. So we looked at early behavior profiles, and that's a study that Dr. Ip has done a similar one with BC data that we did in Ontario, looking at profiles of children for whom we knew that they have autism diagnosis a little later on, in comparison with children with other developmental disabilities. And we found that children with autism already in kindergarten exhibited poorer social and emotional skills than cognitive skills, whereas for then children with other developmental disabilities. My most recent PhD student has looked at equity in assessment for children with neurodiversity. Here you have here we have in BC, we have the foundational skills assessment in grades 4, academic assessment. In Ontario, there is the EQAO education. Well, I've been using this acronym forever, and now I can't. Anyway, it doesn't matter. But it's a standardized assessment of children's academic skills in grade 3 and 6 and later. But what we found was, first of all, children with autism and neurodevelopmental disorders are much less likely to take the test, which is fine. They may be exempt because of their disability or need for accommodation. They get accommodation, but not. It doesn't make any difference. But children with autism get the test a little bit more often, take the test than children with NDDs, and they don't do all that great. But the problem is, well, is that the right way? Don't families of children with autism and developmental disabilities want to know how their children are doing in school? And when I was talking about that with someone, she said, so do you think they should all be made to take the test? I said, no. I think what we're trying to say is there should be other ways to assess the progress of children with developmental disabilities, not using the same standardized test that has been developed for children who are doing fine. So that's kind of a message that I'm still working on crafting, and the paper is submitted, so it hasn't been published yet. All right. We've also looked at children with fetal alcohol spectrum disorder. There is one paper submitted, one older paper, and that's kind of the data from that. There aren't that many because they have in our data sets, because they have to be identified by teachers, and that families quite often don't want to share that. But we compared these children within themselves. Obviously, we didn't compare them to typically developing children. That would not make that much sense. So we have children with FASD and something else, and neurodevelopmental disorders. We found that the teacher-reported prevalence was lower than estimated, but the children with FASD and FASD plus were likely to experience home problems, which we had a report on among those other special concerns. In that newer paper, we're looking at the potential differences between the 2010-2015 data and the later data. One other aspect that really isn't developmental, but is kind of striking, so I thought I'd present that to you as well. We looked at association between unaddressed dental needs and developmental vulnerability. I was working with a colleague at SickKids, Dr. Jonathan McGuire. He's kind of interested in that area, and we had that question, and we've looked at that. And we have only 0.4% of the whole population, but it's still over 2,000 children, because of the numbers. And children for whom the teacher says they have unaddressed dental needs are much more likely to not do well in their development at school entry. So that's something that really is very actionable result, and a startling result of work that we didn't necessarily expect. Very rarely we have an opportunity to look at children longitudinally. And I really tried very hard to convince CIHR that I want to do that in 3 provinces. We were able to get funding only for Manitoba, was supposed to include Ontario and BC. But we've looked at mental health of children with the whole kind of spectrum of special health needs in kindergarten. So the special health needs came from the EDI database, and we were able to link those children with their administrative data sets in Manitoba, MCHP, Manitoba Centre for Health Policy repository. Well, we basically looked at the 4 main diagnoses of mental health up to 16 years of age. So overall, we had, there were just over 30,000 children, and mostly males in the children with SHN group, and then children in SHN group were more likely to live in poorer neighborhoods, but they were less likely to be from immigrant families. And I'm not going to make you guess, but here are the very, very startling results. So for children who are typically developing, about 22% had a diagnosis of mental health in administered database by age 16. Of children with special health needs, it was over 41%. If you look at comparison between, so this is now odds ratio in comparison to children who are typically developing. And just look at the x-axis of that tree, the odds ratio in comparison with typically developing children, in some cases is 40. That's really huge. But if you look at and I don't know that I can necessarily, I don't think I can, I can, it does. Okay, so if you see this variable needs further assessment, just look at that. That's almost 40%. And that's a teacher answering yes to one question. So if, that's kind of one thing sometimes people say, how can you trust teachers? Well, yes, you can trust teachers. If they're doing their job well, they know what they see. They have experience and they really know what they see. So this is something that is really startling, was startling for us to kind of find that. But anyway, that's in comparison with children with typically developing children. And when within the group of children with special needs, you can see here that the physical hearing and vision impairment and speech impairment, if anything, they actually appear to be a little bit of a protective factor. They're not risk factors. It's the emotional learning and teacher assessment of the fact that the child may need more assessment. So what does that add up to in terms of monitoring using data like this for children with health needs? So the advantage is one of the advantages very similar, but it's really more important for children in this group, is there is large coverage for small frequency groups. So you can look at the population system trends there using this data. There's also meaningful link with contextual and neighborhood factors. And again, potential for link with administrative data. As you saw, we saw a really important result by doing that. But challenges abound. One of them is teacher report, the fact that that's where data are based on. So there's potential of maybe improving that part of data collection, but we always have to be aware that whatever we have is very likely an underrepresentation, and we were able to show that what we see is much smaller percentages of children with very specific diagnoses. The same challenges as with using this data for children without special needs, the linkages for equity deserving populations, and they much more likely to also experience intersectionality, be poorer, maybe have less access to resources and, let's say, medical services. Seeing issues from this bird's eye view, which potentially is less harmful if you do it for all typically developing children, but maybe a little bit more harmful, or well, hopefully not harmful, but not adequate for children with special health needs, because it lacks that on the ground perspective. But the way we've always interpreted that is that it gives us an opportunity to ask more questions. It doesn't necessarily answer very many, but it gives us an opportunity to ask more and better questions. So what makes a difference in prevalence of children with special health needs? If we look at it, from that bird's eye view. So one is where they live. So we've looked a couple of years ago, we've looked at association between neighborhood socioeconomic status and percent of children in a neighborhood with special health needs. And what we found is that the poorer the neighborhood, the more children with special health needs. But then when we added actual province/territory, we had 12 in our analysis, the percent of explained variance rose to 40. So 40% of association between socioeconomic status in the neighborhood and prevalence of special health needs in children is accounted for by, so that's 17 versus, although it's not 40%, it's by SES and province. That really translates into what's happening in that province with policies, health, education, which potentially can be changed. So specifically, we repeated the analysis for every province where we had enough neighborhoods to run the analysis. And in BC especially, we found that for every, that association was also statistically significant. And for every one standard deviation increase in SES, the prevalence of children, special health needs in children grows by 3%. Whereas nationally, it's about 2.5%. So where they live does matter. That is probably a consequence of provincial policies, but here's a preliminary study. So that has not been published. We're in the process of trying to replicate this with more data. In BC, full-time kindergarten was introduced more or less at the same time as in Ontario. The difference between the two models was that in Ontario, it also added an early childhood educator to the classroom. So it's full-time learning, but there's also 2 educators. So that kind of made us wonder whether there is, any association between that and the prevalence of children with special needs. So that was a preliminary study of schools where children in schools were units of analysis, and the demographics were fairly similar. But what we found was that there was really no difference between the percent with identified special needs status, but there was an increase in the percent of children with functional impairments post introduction of full-time kindergarten. So that's open to discussion. That was a preliminary study, but as I said, we're following up, and I'll show you so on one hand, that's an introduction, that's a policy, that's a change in structure. But there is another aspect of these type of analysis, and that's called time. I'm not going to suggest that the time per se has anything to do with increase or decrease of prevalence of children with special needs. What it does, obviously, is kind of showing us the secular trend in terms of recognition and reporting on certain characteristics, in this particular case, special needs, functional impairments, and needs for further assessment. So another caveat here is that it's really like that graph is for illustration purposes only, because provinces mostly collect data in waves. So for example, Ontario collects data every 3 years. So there will be no Ontario data in years 2016 and 2017, etc. So this is really just kind of to show that these percentages are growing. So when we add for our Canadian data sets, when we add the percentage of children with functional impairment and needs for further assessment, there's kind of bumps and bumps along the way, as you would expect for frequencies like that, and then they keep growing. When you look at BC, so the bottom line, because that's the lowest frequency condition, is special needs. It has gone up. and the same with children with functional impairments and children with need for further assessment. And, like you see time, but maybe it's not time that's making all that difference. Maybe it's something else. Maybe it's something called global events. So something happened, like if you look at that graph that I just showed you, which I'm going to go back to, some of this, this is 2020, 2019. So you may have a certain suspicious that there were certain events happening, COVID happened. So on one hand, it should be less, maybe because people have less opportunity to see pediatricians and healthcare providers. But on the other hand, it appears to be more. So we're actually looking at that as well. So my master's student has looked at the prevalence. So we took the last few years just before pandemic, so only the provinces that had data pre and post, and looked at the prevalence of special health needs and the categories in it. It was very beautiful graph. So I really didn't want, she made this really beautiful graph with this graphic, but it's actually a little hard to see. So bottom line is that all these categories have increased. So, and the highest relative increase was in prevalence of children with special health needs, even mostly because it's a small percentage to start with, but there was an increase in all of them. And then we looked at the contribution of SES to the prevalence, and we found that it was a steeper relationship post-COVID, but it failed, like barely failed to reach statistical significance, but the graph kind of illustrates what happened. And then we also had data for provinces. So I circled BC. There is a higher prevalence, but when we looked at the specific association between SES and prevalence, we post-COVID, we did not find it in BC. It's true for a number of provinces and overall. So, but the bottom line is that the prevalences of children with special health needs have increased, mostly statistically significantly, in all provinces. So what makes a difference? I think I was able to say that SES does make a difference. So socioeconomic status, it's a proxy for a lot of things, for access to resources, for transportation, for a number of physicians, that take patients. I'm not saying I can say exactly what, but whatever socioeconomic status in the community represents, that makes a difference, whether children have special needs or not. Provinces and policy provinces and provincial policies, whether educational or related to health, early recognition, early identification, do make a difference. Time, in terms of what's going on in particular areas over time. On one hand, the fact that we have more children with recognized impairments and special health needs could be considered a good thing. But time also, and I'm speaking to most of you are clinicians as far as I know, that time also makes a difference in that diagnostic criteria. And often it's for the good for the children, because so many children have gone unrecognized. People would say, oh, they have behavior problem, or they have, or this or that, but really they were kind of on the spectrum of neurodiversity. So to some extent, some of that higher prevalences may be due to better sensitivity. And, these are the things that bird's eye view cannot distinguish. This is something that I'm very keen on potentially exploring further. And obviously, as I said, global events. So I chose an example of COVID because that's kind of what we can look at, but there's opportunities to look at things like wildfires and other global events, global provincial events. So, so how is that an inspiration? And, this is, I'm hoping to kind of, that you are on this journey with me, I did manage to convince you that population level data do shed light on forces shaping the development of children with diverse health needs, that they really do matter, that and the fact that in our medical schools, students do learn social determinants of health, that it matters not only what kind of symptoms a child has, but also who they came with, who they live with, where they live, and where they go to school. That all contributes to their health, not just a particular assessment. But understanding really of their developmental health at the population level does require an interdisciplinary lens, and does require integration of science and community contribution and participation, which is kind of what informs it informs my research so far to some extent, but I really hope it's going to play a huge role in this next chapter here. And as I said, I invite you to kind of jump on that journey with me. So is centering a family of child with disability in the research progress. Like the bird's eye view is not just seeing things from a big perspective, but it's also limiting the opportunity to connect with families. But also, so that's kind of one thing, and I know you're good here with that. The second one is the finding good things in letting children with developmental disabilities lead normal lives. That's the F words in child development, which was developed by my mentor, Dr. Peter Rosenbaum, and his colleagues. And I know I'm really running close, but I just kind of wanted to highlight that the position, that the chair that I'm really very honored to hold is joined between Sunny Hill, BC Children's Hospital, and Human Early Learning Partnership, who have this child development monitoring system. I'm also part of a group that developed the global scales for early child development, so monitoring early child development up to age 3. So I'm hoping to kind of incorporate that one way or another. But really, bottom line is that I really hope that I'm kind of hoping that I'm going to contribute and listening to everything that's going on and potentially bridge. I think the Sunny Hill represents this kind of individual perspective, family perspective that we really need in the research, whereas the Human Early Learning Partnership really represents this kind of population view. And I'm really hoping that we can bring the two together. And that's pretty much it, except I really need to thank everyone. So Clyde Hertzman, Dan Offord, and Fraser Mustard, who were my mentors, my colleagues from Offord Centre, my team, Equity from the Start at the Offord Centre and McMaster University. And at the bottom, like there's our team of some of the research projects. And that was a meeting in Vancouver last year. And there are colleagues from here, from Saskatchewan, from Manitoba, Nova Scotia, and Ontario. And I think that's it. Thank you for listening. All right, a little overtime. Final thing.